Thank you for having me. So I'm Adrienne. I'm the Chief Experience Officer for the Cleveland Clinic. I'm a neurologist by training and an ethicist, and have spent the last couple of years thinking a lot about experiences of our patients and certainly of our clinicians. So interested to share with you some thoughts on that. So I want to just start by sharing a reflection. Has anybody ever seen this picture before? It's René Laennec, a French physician in the 1800s, who was caring for patients. And at that time, the way that you listened to the heart was to literally lean in and put your ear right to the chest of the patient. And in that way, you could auscultate disease of the heart, as well as rhythm, valvular abnormalities. That's how good it was. And as he was doing this over time, he had a thought about how if you actually connected wood to the ear when you were playing as a kid, if someone tapped, for example, on the other end of the wood, you could hear it, right, so vividly. And he had this idea when he was listening to the chest of a woman who was somewhat overweight, and also a woman, and he became uncomfortable with leaning in to her chest and keep moving his ear around her breast area to try to listen to her heart when she was suffering from cardiac disease. And so he subsequently rolled up a piece of paper and stuck it to the chest wall and could auscultate the heart beautifully. And thus the stethoscope was invented. I'd like you to think about, as I talk today, this notion of how innovation that you just heard described and in that story, how it has the actual, not just conceptual ability, but the physical ability to either move us closer to the patients we serve or further away. This is him with what he wound up inventing as it began to take actual shape. I'm going to spend some time talking to you about the what, the who, and the how that I see on the landscape as an organization constantly thinking about how do we innovate and yet also drive exceptional experiences for patients and our people. And I'm going to start with something we did just recently, which was, you know, there's lots of information coming at us. And I heard this described beautifully once as dark data, meaning there's so much of it we actually don't know what to do with it, nor are we giving more people time necessarily to look at it. And so I was asked by our organization CEO to look at all sources of data that we have that's coming from patients, whether that's from social media, emails, complaints, grievances, patient satisfaction surveys, anything we could get our hands on to figure out what is it that patients want from us. And you've probably seen this described in many spaces, but for us this was a fascinating exercise in trying to collate a lot of different data sources. And one of the most voluminous data sources is patient satisfaction surveys. And so I'm giving you a sample which actually represents what we found from the whole, from all of that analysis. And that is, we pulled tens of thousands of patient satisfaction comments and results and then sifted through all of that to distill it down into a very simple message for you, just for you. The good news is that patients actually, although it's a myth in many clinicians that only angry patients write, that's just not true. 70% of what patients had to say about us was actually positive in our experience, and 30% was negative. And I found this really interesting. So what we're best at is actually what patients say we still need to keep working on. So communication and service is actually what they want us working on at the same time. And in addition, you'll see on that negative feedback piece, access starts to creep in and delays. So a simple question that sort of jumped into my mind was, Well, if we know that one of the major pieces of data from our patients tell us that they don't like the way we manage delays, what innovative solution do you have to fix delays in your organization? Because we don't have one yet. Actually, we have patients wait and we don't tell them that they're waiting, and we don't update them as time goes on. Nor am I aware of any organization that does. So how are we creating a solution to what may be the most basic of problems that is really important to the people we serve? This is what all sources of data told us. And this is a year's worth of data. Access, being able to access your service. I don't care if you're fantastic at what you do. If patients can't access you, it doesn't matter. Service excellence, I don't typically call patients customers, so service excellence. How do we deliver service? Is it easy and seamless for you? Am I adding to your suffering, or am I taking away what I call avoidable suffering? Communication. So despite communication being at the core of wrong site surgeries, right? People don't speak up to tell you it's the wrong leg that they're operating on because they're afraid of the surgeon or afraid of the consequences of that. So human factors impacting communication. So despite wrong site surgeries, safety problems, quality problems, malpractice problems, all being clearly tied to communication, I ask you, what novel innovation are you creating at your organization to ensure effective communication between patients and clinicians? I'm often met with that amount of silence. And we faced the same question. Delays in waiting, as I mentioned, in environment. So when people are waiting for you, what does that environment feel like? Is it a healing environment, or is it one that adds stress to the person sitting there? So I want to spend a couple minutes talking about access. I mean, some of you're interested in this intersection, perhaps, of innovation and access. And our thought has always been the Cleveland Clinic offers there's another place called Cleveland that offers healthcare, just to back up. And our belief has always been that we offer world-class care, but now it's anytime, anywhere. That's actually part of our slogan, is that the idea is there will be no walls of healthcare. And in order to achieve that, we've done a variety of things, as I'm sure many of you or your organizations have. So it's not just patient portals, it's not just online scheduling, it's not just phone calls, figuring out how to better manage them, same-day appointments, which we instituted in 2011, and about texting your providers to get faster access to them, distance health, obviously virtual visits, but also thinking about some new things, telemedicine, stroke mobile, e-hospital, and open clinics without appointments. So in the majority of our family health centers now, you can come anytime. Open at 6 a.m. till 10 p.m., for example. You don't have to have an appointment, you just show up. So you're obviating the need for all this hassle for the patient's lens to get to your services. I want to talk quickly about some of those. So many of you have a patient portal. This is ours, MyChart. It's a means to both schedule appointments as well as communicate with patients, built outside of the regular EMR. We've also thought about distance health. How do you touch the patient? And I just want to highlight here a couple things. So our philosophy certainly is that virtualizing the practice of medicine where it makes sense. Meaning just doing it because it's sexy and new isn't really our goal. Our goal is to do it where it makes sense for the patient, not just for us. I want to highlight two things here. One is remote imaging upload. I mean, think about this problem. So I'm a multiple sclerosis physician, and patients come to me from all over the country, and they carry this stack of records, and I spend my time uploading images during my visit with a patient. I copy their CDs into our system. We just fixed that problem. I mean, think about that. If one of the major causes of clinician dissatisfaction and burnout is lack of time and autonomy and doing the things that I was meant to do you think I had a vision when I was a med student that I'd be uploading CDs? right? So do you have a system where these records get uploaded by the patient rather than your clinicians from home? It should be easy. We can do more by making their lives easier. And it serves the patient just as much as it serves the clinician. Remote patient monitoring, I'll highlight a couple of these. So certainly we went online with urgent care. So anytime, anywhere, you can log on, give us a call if you've got a common problem, and we'll deal with it. I'm sure many of you have thought about this. Another innovation that we had, which I think is relevant just to sort of put into your consciousness, is this idea of stroke care across the country. So how many of your lives have been touched by stroke? Hopefully you haven't had one, or your family members, but many of you, it sounds like, have had somebody who's been touched by stroke. So big problem. And the old model was, right, maybe you had some symptoms, hopefully you called the 911 as soon as you had them, as opposed to going to bed. But let's say symptoms onset in the morning, someone calls 911, the EMS stroke, the ambulance comes out to your house, they pick you up, they assess you, then they drive you over to the ER, and then you have to get into the CT scanner within 30 minutes or so. It has to be read, and then they decide you might have had a stroke, and then maybe they decide to give you medicine, right? That's the old model. Well, the interesting thing was that many physicians actually aren't comfortable giving the medicine that you need to fix the stroke problem, despite it being FDA approved, despite it being appropriate based on many clinical criteria. And so now, this innovation allowed a stroke ambulance staffed by people who had expertise in stroke to drive with the regular ambulance to your house. They assess you at your house. They put you in the stroke mobile, which scans your head because it has a built-in CT scanner in it. They telemedicine with a stroke neurologist back at main campus, and then they decide to treat you right in the ambulance outside of your house. So dramatic cut downs on time to treat, dramatic impact of outcomes for stroke patients. Millions of neurons die per minute that they don't get oxygen and blood flow. This translates to real meaning. And so this was an innovation that's rolled out across Cleveland, and certainly requires both political change as well as clinical functional change, changing behavior of who's going to decide when and where to treat you how, in the interest of the patient. Another idea that certainly you're seeing and we're seeing is this concept of remote ICU monitoring. So who would have thought, right, you'd ever actually be monitoring remotely ICUs across the state or nation? And certainly this is expanding as rapidly as telestroke or telemedicine has. That on the screen, right, simply who has some exposure to EICUs? A couple of people, okay. So the idea being you have a team of professionals, ICU professionals, looking at a screen. They can essentially click on any patient. It pulls up all of their vitals, their most recent chest x-ray, and you can manage them with a button remotely in the room where you can communicate with the nurse sitting at the bedside. Right? Looks like the vitals are going up. I'd like you to give this, this, and that. Call me back in a few minutes, or I'll track the heart rhythm. Okay? So again, expanding your ability to care for patients remotely, without walls. And many of you, of course, are working on virtualizing chronic disease management. I'm not going to spend too much time on that. I have two questions, though. One is, these are for myself just as much as they are for you. One is, with all of those innovations, so think about, for example, the innovation of just opening the doors and letting patients come whenever they want. My question is, what did we do on the back end then to make the clinician's life better? Because if you just open the doors and you say, clinicians, now you're going to work from 6 to 11. I know you used to work from 9 to 5 or 7 to 5, but now isn't it great? You're going to serve patients from 7 in the morning to 11 at night. It's not a sustainable innovation, right? We actually have to change the way we deploy our own people to provide that sort of flexible service. And I would submit to you that we have some work to do around that. Just as we're innovating for patients, we need to be innovating that same flexibility for the people who are serving the patients. And that part we don't talk about very much. The second question I have is around how is all of that innovation or data helping me with this problem? So I think it was a Saturday or maybe a Friday afternoon, I was out of the hospital and I got a phone call. And the phone call was from a colleague who works with me who said, I just don't know who to call. I've called a couple different people. I haven't gotten anywhere. I thought I'd try you. I'm not sure that's a rave review on me, but I said, great, how can I help? And she said, well, I have some family friends who are in the hospital, and their 21-year-old son just graduated from Ohio State, got diagnosed with gastric cancer in December, and now it's January, and he's dying. And he's been waiting 3 days in the hospital to get IR to place a drain so that he could go home with hospice. And I said, great, what's the problem? And they said, well, we've been told since Tuesday that he would get the drain placed, and now it's Friday. And I said, well, what are you talking about? I mean, that's like 3 days, right? And they said, well, every day we were told by IR they were going to place the drain, and they didn't place the drain, and so now it's Friday. And now they're worried he's not going to be able to die where he wanted to die. How do I fix that problem with all of the sexy solutions we have? That's a basic problem, right? I mean, that's a problem with us identifying problems with the way we deliver service and then real-time solutions for them. So of course we solved that problem, and he went home and died that weekend with his family. But as an executive, my question was, well, where's the service? Where's the data solution for that? Where's the real-time service solution for me to know, why am I finding about that problem on Friday? That should have been fixed on Tuesday or Wednesday. That's the reality of what's going on in the hospital systems that patients will be talking about for years, weeks, months, days. That's the reality. So it gets me thinking about, who are we serving? Right? Well, of course we're serving patients, right? We've done a lot for patients. We have pet therapy, we have healing services, we have all these services to attend to the emotional, spiritual being that is the patient. Great. We created new gowns for them, right? We innovated in the design of the physical gown that touches the patient. Great, right? To preserve their human dignity. How many of you have actually put on a gown? Yeah, you don't act like you haven't put on a gown. All right? I mean, I don't know if you've had this experience, but when I take off my clothes to put on a gown, it's as though my humanness sheds with my clothing. And then you feel weird, right? Your clothes in a little pile, and now you're in this starchy thing. And so how could we innovate in our design to make people feel more human even when they were going to subject themselves to a gown? How could we preserve privacy? So innovation in interesting spaces. I put these two pictures up. I won't spend much time on them, but let's say, for example, the one on your left is the front of the Cleveland Clinic currently. And there's a story around this which I love, which is it's kind of this donut-shaped, you can see the water feature is kind of this donut-shaped thing on the front. And many people have visited the clinic. We use space very intentionally. And there's this donut thing, and the water feature is a flat surface of water. And it used to be that the front entrance of the clinic was a smoker's center. Any of you have that problem? And then we redesigned the space, and as we were looking for designers to come in and sort of present what we were going to do with the front of the Cleveland Clinic, maybe a water feature, people came, and of course you know what they said, right? Well, you need lights and fountains, spiriting water, and all the directions. And to his credit, right, our CEO, who's a cardiac surgeon, looked at them and said, well, what are you talking about? Don't you understand that the people coming here are loaded with anxiety? Actually, the most calming thing I could think of for them to see upon entering our facility is a smooth infinity edge body of water. That to me feels like calm, like peace, like knowing what patients are carrying when they come and then changing what you do, what you look like, what you sound like to meet that. So great. So if one of the keys to patient experience is caregiver experience, what are we actually doing for our own people? And how does what you're doing impact our own people? I'm fascinated with this question because we actually haven't proven this with data. So I was just talking about, so every hospital does patient satisfaction data, every hospital does patient engagement data, every hospital does patient safety data. So what have you learned from the intersection of all those pieces of data? Is it really true that if your clinicians are super highly engaged, that they deliver safer, higher quality, more satisfied patient care? Can you demonstrate that to me? Because we haven't done that work. It hasn't been proven actually in data sets because those data sets haven't talked to each other. So it's an opportunity for us. And I would submit to you that some of the innovative work actually has to be done on how we care for our own people as a gesture of enhancing care. We outlawed smoking, as many of you have. If you go into our cafeterias, we post everything about food you would want to know. We don't allow trans fats or high fructose in any of our vending machines. Again, with the belief that we should be modeling what we're talking about. If we care about patients, then we also care about the people who serve our patients. Lots of people talk about patients as design partners, right? I hear that a lot, which I think is great. You take an idea, bring it to patients, or you have patients work with you on that journey to create the idea. I would also submit to you we still have work to do around incorporating our own people in the great ideas that we have at various levels across an organization. And we call this, of course, if any of you are familiar with CI, right, go to Gemba. Right? You can't change lab wait times unless you spend some time sitting in the lab yourself and doing the work, right? And understanding the work. We all have a role in doing that. We take our board members and trustees on rounds, right, to go see what the work looks like so that they can hear from patients themselves what ideas we should be focusing on as an organization. Right? Not just the polished presentation in the mahogany boardroom about how great we are in safety. Why don't you get out there and actually see it and hear the good and the bad about where we are with safety? One thing we did was we got serious about communication, and this was important to us. So we've trained 5,000–6,000 clinicians in a relationship-centered model of communication with the idea that whatever technology, whatever innovation you come up with, that's great. But if your doc cannot communicate effectively, guess what patients say? Well, I know you've said some of these things at your own dining room tables, right? You say, well, I heard he was a great doc, but I left because he doesn't listen to me. Or I heard she was fantastic at knees, but it's too hard to get in to see her. Or I didn't like the way that she didn't see me after surgery. This is the reality of what people say. So then I submit to you, if it's one of the top priorities identified by patients, where does technology feed in to help us be more effective at communicating? So we just published a paper on this experience, training these thousands of clinicians, and its impact both on empathy, burnout of the clinician, as well as on patient satisfaction, which I think is the largest study of its kind nationally. This is important. And when I looked for technologies, just as an aside, I looked all over for technologies that would help me communicate more effectively, help my clinicians communicate more effectively with patients. It's a little tricky to find a technology that understands the gravity of the work and is responsive in that environment and can extend my way of communicating to the patient. It's a ripe area for figuring out how we can do better. We evolved a lot of work around this. We have an entire center dedicated to this work, and many clinicians still look at us like this, which in my mind is what I call the healthy skeptic, right? I mean, you're kind of like, what? You're working on communication skills, or you want me to communicate more? I'm really good with my patients. How many of you are clinicians? And how effective communicators are you? Very good. I just saw some, it's like, very good. Very good. Well, interestingly, if you think you're really good, you won't change. If you think your current data management system works, guess what? You won't change it. It's the same with human behavior. If you think you're very good, you won't change because you don't think there's anything to change. Why change? I'm very good. My patients like me. And that's just not true, actually. I'm sorry. Come see me after. But right, we all have blind spots. And so I submit to you, part of the how we're going to move on this journey from innovation and population management and all the great new things we could do is really thinking about how are you going to drive something like transparency. So all of this data that you have, I would submit that the purpose is actually to make it transparent to people to change behavior and practice. This is a hot topic in my world. I don't know how familiar you are with it. So in our world, there's a JAMA article 2 years ago published that said about 60% of patients are now going online to pick their doctor. 60%. That's huge. And the problem with some of the websites that rate docs is that there's no guarantee. So if I want to rate Nick, which I'd be happy to do right now, if you want to rate Nick, right, and let's say I'm his neighbor and I don't like the way he cuts his grass, I can go online and sign on to one of these websites and I can say that Nick is the worst neurosurgeon I ever saw and I don't like him and please never go see him if you're a patient. And there's no guarantee on those websites that actually confirm I'm a patient of Nick's. That's reality. And yet 2 million people visit my comment a month about Nick. So organizations can take data, their own data, and own it and make it visible to patients so they can make better choices. This is a big deal because it includes comments. Right? So you can imagine the world is shifting to quality data that's transparent to patients, safety data that's transparent to patients, and patient satisfaction data that's transparent to patients. And patients, when we took this to hundreds and hundreds of patients and said, what do you think about this? They all said, we want it. We are capable of figuring out what's positive, what's negative, who knows what they're talking about or not, but give me the information. So we did this in April of last year. You feel free to Google me anytime. And this is specifically around the things that are important to patients. I'd like to see us move from patient-centered to really a discussion around human-centeredness and relationship-centeredness, not patient-centered. Patient-centered implies there's one person in that equation, and there's never one person in the healthcare equation. We have a role in that, in how you do what you do and what you create. The how of what we do seems to be more important. I'm going to wrap this up. So many of you may be thinking about developing these biopsychosocial models of patients, right, that break out their functional status, their cognitive status, their alcohol abuse, their physical activity. I think that's great. To me, the most important questions, however, are what worries you the most as a patient? What brings you joy? What's most important to you? And if we miss those questions, I don't care what your model looks like. These are the questions that matter to human beings. I also comment that those models that profile patients, where is the one that profiles us? Right? I mean, isn't the dream state that you're matching the right clinician with the right patient? Why are we thinking that if you just profile the patient, that's okay? We want to profile us. I mean, I'm a doctor. It's a weird double standard. And I would submit to you, if we want them to be profiled, guess what? You should be thinking about being profiled so that we can make those matches and figure out how do outcomes change when you're with the right person for you. That's the question. Not is it nice? How does your care change? The why, well, I told you the why in the beginning with the story of Laennec, that as we innovate and move physically further from the patient in some ways, I think the why is also about pulling us back in, thinking the greatest of technologies will figure out when to pull away and when to pull back in, because our greatest role is actually to make what's invisible visible, right? This face of the human we serve. How do we make that visible to ourselves and each other? Thank you for all that you do, and I open it to questions.